In the United States alone, more than 3.5 million babies are born each year. That's 3.5 million pregnancies and 3.5 million births. Each one a life-changing event. What many don't realize is that nearly 1/3 of these births, over 1 million deliveries, happen via cesarean section. And the reality is, the recovery process can be physically and emotionally overwhelming. For many, a C-section is a necessary intervention to ensure the safety of both mother and baby. But what happens after surgery? C-sections have an increased risk of PTSD and a negative birth experience than vaginal births. 80% of C-section patients experience significant postoperative pain. 1 in 7 mothers develop postpartum depression. Postoperative pain is intense, sometimes debilitating. Up to 80% of C-section patients struggle with pain that can delay recovery. And beyond the physical healing, there's another crisis. One that's often invisible, but just as damaging. Postpartum depression. 15 to 30% of mothers develop PPD, making even the simplest tasks, bonding with their baby, getting out of bed, feel impossible. An alarming 50% of mothers diagnosed with PPD think about killing themselves or their neonate. We know pain and mental health are linked. Poor pain control can increase the risk of depression, and untreated PPD can prolong recovery, making it harder for new mothers to care for themselves and their babies. Postpartum depression doesn't affect just the mother. The stress and emotional strain can place a significant burden on the family unit, potentially leading to strained relationships and creating a ripple effect that impacts family dynamics. Yet, despite these connections, our current approach focuses heavily on pain relief, often with opioids, while mental health remains an afterthought. But what if we could treat both, pain and depression, at the same time? What if there was a solution that worked quickly? Reducing the need for opioids and promoting better recovery. That's where ketamine comes in. Ketamine is an NMDA antagonist, which means it blocks specific brain receptors involved in pain transmission and mood regulation. Unlike traditional antidepressants that can take weeks to work, ketamine has been shown to have rapid antidepressant effects, often within hours of administration. Ketamine can offer immediate improvements. And prevent depressive symptoms from occurring, allowing mothers to feel better bonding with their newborn. What does the research say? Studies have shown that low-dose ketamine, 0.25 to 0.5 milligrams per kilogram IV, administered during or after C-section, significantly reduces postpartum depressive symptoms and pain levels. Even more promising, S-ketamine, a more potent enantiomer of ketamine, has demonstrated sustained effects lasting up to 6 weeks postpartum. S-ketamine has been studied as an alternative to IV ketamine due to its higher bioavailability and longer-lasting effects. These findings highlight ketamine's potential as a dual-purpose therapy in obstetric anesthesia. Beyond its impact on depression, ketamine also played a significant role in postoperative pain management. Patients who received sub-anesthetic ketamine doses of 0.25 to 0.5 milligrams per kilogram IV immediately post-C-section reported lower pain scores and required fewer opioids during their recovery. By reducing opioid use, ketamine helps minimize the risk of opioid-related side effects such as nausea, sedation, and dependency. This is particularly important for postpartum patients, as opioid use during breastfeeding can have adverse effects on newborns. To measure postpartum depression symptoms, the Edinburgh Postnatal Depression Scale, or EPDS, is most commonly used. This scale is one of the most widely used tools for identifying postpartum depression, with a score of 10 or higher indicating possible PPD and 13 or higher suggesting a major depressive episode. Research studies have shown a significant reduction in EPDS scores among postpartum patients who received low-dose intravenous ketamine. Within 24 hours, many patients reported an improvement in mood, and at follow-ups conducted at 1 week and 6 weeks postpartum, their depressive symptoms remained noticeably lower compared to those who did not receive ketamine. Now, let's talk about dosing. Our research identified several key dosages that provided optimal results for both PPD and pain management. Ketamine, 0.25 to 0.5 milligrams per kilogram IV administered immediately post-C-section, significantly reduced pain and depressive symptoms. S-ketamine, 0.2 to 0.25 milligrams per kilogram IV, with effects lasting up to 6 weeks postpartum. A patient-controlled analgesia regimen with 1 to 2 milligrams per kilogram of ketamine over the first 24 hours showed extended benefits for pain relief. These dosages align with current research on ketamine's antidepressant and analgesic effects, reinforcing the idea that it can be safely integrated into standard postpartum care protocols. This means that ketamine has the potential to transform how we manage postpartum recovery. Adapting ketamine into practice can decrease the incidence of postpartum depression and help mothers recover physically and emotionally, leading to better long-term outcomes. As anesthesia providers, it is up to us to stay informed, advocate for evidence-based practices, and help bring innovative solutions to practice. Ketamine is more than just an anesthetic. It's an opportunity to provide holistic, patient-centered care that improves both physical and mental well-being. So, what's next? Continue exploring ketamine's potential, discuss its benefit with your colleagues, and consider how it might fit into your own practice. As anesthesia providers, we have the power to advocate for our patients. The power to positively impact the postpartum period. The power to help mothers recover and bond with their babies. the power to make a difference.